I'm going to talk a little bit about our foundation's general approach, which is to look at systems change represented by the house there on the screen. We do get down into direct care, the open doorway, and there we focus specifically on uninsured populations as well as underserved, most recently with a heavy focus in the Medicaid dental population. But workforce falls up at sort of the higher level, and so we do take a broader focus to look beyond just the uninsured when we consider workforce requests. I'm going to talk about two grants that we have in the workforce area today, one being the Family Medicine Scholars Program with the North Carolina Academy of Family Physicians, and the other being a teaching health center, and these fall nicely into sort of the medical education field as well as the postgraduate residency program. So I think they follow neatly on Cleese's presentation. The first program, the Family Medicine Scholars Program, is really aimed at increasing the number of North Carolina medical students who commit to primary care and family medicine in particular. And the Teaching Health Center program you may be familiar with from the federal initiative to promote teaching health centers, but that's going to increase primary care providers' early career experience with safety net organizations and the populations they serve, the uninsured and vulnerable populations, to both increase the likelihood that they'll practice in these settings, stay in the settings following a loan repayment, for example, and we're finding that there are some distinct training benefits as well to having them do their postgraduate work in the health center environment. I'll start first with looking at the Family Medicine Scholars Program, which is, again, at the medical school level. In North Carolina, family physicians represent 75% of the projected need in the state, and we have about 10% of our medical students a year committing to family medicine, with only half of those staying in the state for residency. So this program provides support to medical students who are considering family medicine to have an intense experience in it fairly early in medical school, starting between their first and second year, to engage with mentors in an externship setting. And those mentors then provide support to them to stay faithful to their vision, their idealistic vision as they enter medical school to match into primary care ultimately. I've put the pyramid or triangle up there to show that this program sort of provides varying level of support across a large spectrum of students. At the bottom there, the focus is on supporting family medicine interest groups at our 4, soon to be 5 medical schools with, as Kim mentioned, the DO school starting at Campbell. And so the family medicine interest groups get financial support to bring in national level speakers. The students have a highly subsidized rate to join the North Carolina Academy of Family Physicians. And so as a sort of result on the right side of the pyramid from our first 3 years of this project, they've increased student membership in the academy at the state level from 100 to over 600. So a much stronger student interest in sort of the leadership component of family medicine and joining the association at the state level. As we move up the pyramid, students also get support. A smaller number of students will get support to attend the annual meeting, so they've increased student attendance at the annual meeting from 40 to over 100. A smaller number of students get externship support. And at the very top of the pyramid, 7 students a year are selected to receive an up to $10,000 stipend when they graduate from their program, or actually after residency, they could get the full $10,000. They'll also get 2 month-long externship experiences with a mentor who's selected for their sort of innovation and commitment to leadership in family medicine. And so we've had our first cohort of 12 match this year, and 10 of the 12 matched into primary care, one of those being into pediatrics and the rest being into family medicine. Incidentally, one of them did match into anesthesiology, so we're not quite sure what happened to her, but apparently she was really challenged to decide between family medicine and anesthesiology at the end. So we have had a couple of course corrections and some findings in this program over the first 3 years. we found that clinical experience with a physician mentor is really critical between the first and second year. That increases students' experience with the field early on, and also gives them a mentor that they can touch base with as they get through their medical school career, and may encounter folks who tell them that family medicine is not for them. Having a staff support position at the Academy of Family Physicians has been really key to provide that support to the family medicine interest groups. And I think as this program evolves, the Academy is really going to work to establish more externship opportunities that may be a shorter time, and then select students to receive this higher touch intervention after an initial short externship. We did have one scholar who matched this year who matched into the clinic where his externship had been based, and so we consider that a really strong success. And on the next slide, you'll see a photo of him while he was in medical school out on a home visit with the doc he was matched with. There's some long quotes up here on the slide, and I'll allow you to read those while you tune me out, but they are really representative, I think, of students' experience in the program. The first at the top speaks to the real strength of this program. In their written evaluations, students all speak to how diverse the practices they're matched into seem, how many more conditions they see, and how many more procedures they're able to perform themselves as a result of that experience, the cradle to grave, full spectrum care, the diversity of the patient population. They also report, as you would expect, increased confidence. Several of them sort of get involved in the student clinics back on campus immediately after completing that first externship because they've gained some confidence. And a lot of them sort of comment on their new perception of family medicine, the ability to specialize within family medicine on topics such as women's health. I think a lot of them, because the practices that the externships are located in are largely rural, really get an increased appreciation for how much care is provided at the primary care office. They also speak to the decreased perception that family medicine, family docs out in rural areas are alone. They really do see that there's a high level of support for them and many peer connections. We actually have a number of them that live with the docs that they are matched with, or with residents who are out in those communities, and they really do comment on the work-life balance that these folks are able to achieve. It does not hurt that many of them are in the mountainous areas of our state that are so beautiful, and so they talk about mountain biking and whitewater rafting, and it really does seem to be driving them to an increased appreciation for rural practice. On the bottom of the slide, you see what the program is designed to inoculate against. We really want to get at students early, because even in the faculty in medical schools can downplay the impact a family doctor can have, and sort of we want to give them a more accurate perception of family medicine and provide this touch point that they can refer back to when they're told by faculty or other students or anybody that, you know, they're too smart for family medicine, which is what we hear about. We will move on now, thank you, Kim, to talking about the Teaching Health Center program. So this is shifting gears. We've provided support to UNC Family Medicine program, where they have, I believe it's 10 residency slots, to add 2 slots there. So it's an additional 2 slots in the state for family medicine residency. There is federal funding available for this, but for a variety of reasons, UNC decided not to pursue that, and we have been able in the state with local funding to be able to create these 2 slots. It's a partnership. Duke Endowment has come on to provide additional funding after we got it started 2 years ago. Another North Carolina entity has received the federal dollars to develop a teaching health center in the western part of the state, so we're very excited that there's some learning going on within the state about how to do this right. But this essentially puts residents in a community health center, a federally qualified health center, for their residency. and the residents have their continuity clinic experience, in this case at the Prospect Hill Community Health Center, a rural federally qualified health center that's about 27 miles northeast of Chapel Hill. Now 27 miles may not sound like a lot to you, but you get about 6 miles out from the city center and you are rural. So this is, I've visited this site several times. It is very rural and it feels indeed remote. We're hearing that residents in the family medicine clinic at UNC are extremely envious about the two teaching health center residents just because they're getting a much broader scope approach. They have that distance from the hospital services, and I'll tell you, nobody is driving from Prospect Hill to UNC to get some of those hospital services. So they're providing just sort of a broader scope of care at the community health center than they would at family medicine at UNC, which is just down the street from the hospital. They're really integrated into the team. There's a greater continuity with patients. The items I have listed on the slide really represent some of the special opportunities that residents have in a teaching health center. And ultimately, we hope that they'll feel better prepared to be out in health centers, to be employed by them when they are completed their residency. They see a broader scope of supportive social services with in-house dental, in-house WIC, pharmacy, and just a stronger integration into that team. In terms of what we found out from doing that, it is a lot more than just 2 new residency slots. So there's had to be a strong mission fit between both the health center and the residency program at UNC, and I think that's required a little bit of compromise on both sides. This slide describes some of the key considerations for each of the entities. I know UNC, in conjunction with developing the teaching health center slots, they also made a significant move towards offering some experience with vulnerable populations, the underserved, by creating an area of concentration for care of the underserved, and that's been fairly well enrolled by students who are, by residents, who are at UNC Family Medicine. But then we've also made course corrections along the way. So 3rd trimester ultrasound was not a skill that residents at UNC were getting a strong experience with, and we found that that's really important in the health center environment. So they've sort of beefed up their training in that area as an example of one thing that UNC is doing differently, and they're doing that for all of their residents rather than just the teaching health center residents. And then on the Piedmont side, I think they overestimated the financial impact that the residents would have on the clinic, because I think they did, for a variety of reasons, residents have a more heavily weighted patient panel to the uninsured. And so there hasn't been the financial impact that the health center had hoped to see from the increased visits they provide. The residents, they expect to see an additional 3,000 patients above and beyond what the health center had been providing prior to having the residency, so that would be this year. So that's a significant increase in access, but it also has caused some practice management considerations because, you know, and seeing an additional 3,000 patients calls for an increase in capacity at the clinic. The other thing that they did that really sort of to change the program beyond what they had envisioned is they created separate match numbers for those 2 new slots. In the first year, they selected, rather than 10 residents, they had, you know, they matched 12, and then they selected from those the 2 that would match into the teaching health center. And for marketing purposes and, you know, a higher caliber of match and resident, they decided to separate those out because they felt like they were losing out on residents who would for sure want to match to the teaching health center but might not otherwise want to match to UNC. So that's just a small lesson learned that if those of you who are considering this in your states may appreciate.